Uh, Sorry guys for not posting a video for a while. As I'm sure you've all been aware, it has been a very brutal winter in the NHS. Certainly the worst I've ever seen, and that includes all of the last 3 years. And by all accounts, the worst that we've ever experienced. Thousands of people have died. Many more have suffered long-term disability because of it. Delayed access because of strokes and heart attacks, etc. So it's been a busy one. It's been really full on. It's still, at levels that we would normally see at a busy winter right now. And we're in a bad state. I mean, the NHS everywhere is in a bad state. But I did want to share this with you. I think this is really important. We are certainly entering a new phase of the government's strategy to extract money and wealth from the NHS budget. We've already seen that through the initial years of COVID. We saw, billions being siphoned off, really, certainly redirected to their mates, their landlords, their family, donors, and billions have been made and taken away. And the worst thing, that money would have saved so many lives this year. Through COVID, it would have saved loads of lives. But right now, had that money been put where it was supposed to be put, then it would have saved thousands and thousands of lives, and not traumatized me and my colleagues, really. I mean, people are leaving more and more after a brutal winter like that. I don't think many of us could take another one of those. But yeah, so they are moving to their next phase, and this is how they're camouflaging it, and this is how they're packaging it, just like with the PPE scandal and the test and trace scandal, cloaked it around using the pandemic to try and fulfill their long term goal of, taking more money out of the taxpayers and out of the NHS. Now we know that the industry in the UK is worth hundreds of billions of pounds. It is a massive, and in their perspective, untapped amount of income. At the moment, we've about 8% of our resources, the NHS budget, go to private care, directly to private care. And the plan they're putting in place is going to see much more of that go, and what that's going to leave in its wake is a diminished NHS. National Health Service is going to be diminished, and we're certainly not going to be able to get back to the level of care we've been delivering, pre 2010. Nowhere near. It's just going to get worse. Access is going to be more limited. The treatments we can offer will be more limited. You have less time to see your doctor, less time to see specialists. It'll be much more of a conveyor belt. So yeah, it's a worry, real worry. I mean, it's hard for me to convey how important this stage is in the push towards making profit from the NHS. So we're going to look at the way that the UK government are trying to pull the money out. We're going to also, just for comparison's sake, we're going to look at Scotland, and we're going to look at how they're using their COVID recovery money, and we'll contrast the two. The main point is, what you will hear a lot from now up until election time will be patient choice. And they will try and package this as, we are delivering patient choice. Patients will get to choose when and where and with who they get to have their procedure. And this will dramatically cut down waiting times. And this is the best for everybody. The reality obviously is far from that, and patient choice, what I'll show you just now, is a way of getting the money to follow the patient, and to enable private companies to be paid directly for patient activity. So if they do an endoscopy, they'll get paid for that endoscopy directly through the patient's own route. So they don't have to rely on the NHS granting them a contract. A patient will have a choice. They can go to a private hospital and get an endoscopy, and that will come from the NHS money, the funds that we pay for our NHS. And all it means is that the overall care we can provide, the services, the treatments we can provide will just diminish and diminish and diminish. Because of course it's going to cost more to get those treatments out in the private sector. And that's the money pot's the same. So we're not going to have enough money left to provide decent care. So one more thing before we go into, and I'll show you the kind of key areas of it. It's talking about treating the COVID backlog. There's no doubt COVID beat the crap out of the NHS. I mean, it really hammered us very, very hard. And we do need to invest to try and recover that hammering that we've taken. But make no mistakes about it. The collapse of the NHS had begun long before that. Even before the pandemic, we had record waiting lists. We had record cancer waits. We had record 4-hour waits. The system was already declining, and if you read any serious health economics analysis on this, the Lancet, Financial Times, King's Fund, Nuffield, Health Foundation, they all say exactly the same thing. It's due to a real terms pay cut, funding deficit that has occurred over the last 10-12 years. We're about 30 billion short every year for the last at least 10 years. And that's across all of the analysis show that. So this has been in the pipe for a long time, and now they have a nice little shield to push it through, and that is, we need it for COVID recovery. So let's have a wee look. This is the document that was produced. It was actually initially put forward by Sajid Javid, and we can see some very clear issues. Hold on a wee second, I have the wrong document. There we go. So this is the care pack. This is the plan they were putting forward. It's 6 billion they're going to put in, and what they're focusing on is to reduce the election losing waiting lists. So obviously if people wait more than 2 years, it looks bad for them at election time. 18 months, 1 year, exactly the same. So their priority, and if you have a look, this is number one, is to reduce those long waits. Don't get me wrong, I deal with patients every single day that have to wait for care, and it's horrible. It's truly horrible to see someone, unable to mobilise around their house because their knees totally gubbed. I've got a guy that's hip so bad he might have to go to a nursing home, and actually he's fine otherwise. He just gets his hip done, and we're fighting to get that hip done. We're arguing amongst ourselves to try and get that to push him up the priority list. So it's horrible, and there will be deaths because of the delays, unequivocally. Not to mention the level of suffering, the level of demand on relatives and people that are having to care for them, and there's definitely a loss of workforce, huge loss of workforce related to that. One of the reasons the productivity is so low in the UK, because people can't get access to care. So there's no doubt it's a massive issue, but it's not the number one priority. Absolutely not. If you can't get an ambulance to someone who's having a heart attack within 18 minutes, within 20 minutes, consistently, I'm sorry, the priority isn't going for to reduce the 2-year waits. The priority is to shore up your urgent and emergency care, and your priority is to shore up your primary care, because it stops the waiting list growing. Believe me, it stops the waiting list growing, and it's actually where the need is definitive. If you don't do that, people will die, unequivocally. So that's how we save lives now. So the priorities are all wrong in the whole thing, but it just stands out a lot. That's their first priority, and they want, fantastically, amazingly, they're not talking about treatment. They're talking about diagnostics. And what they want to do is they want to put, get diagnostic hubs up and running, to use our money to build more diagnostic centres. No capacity for treatment. There's no extra funding so that we've got more surgical time, or we've got, more radiologists to read the scans, or more medical time to manage the complications. None of that, or primary care time. It's just there's going to be this big swell of all these new diagnoses with nowhere. We'll get to that. There isn't nowhere, with certainly nowhere in the NHS to go to treat it. So again, priority number 2, believe it or not. And then we do talk about cancer treatment, and they're absolutely right here that we need to reduce this 62-day wait, and we do need to prioritise that. That's absolutely right. And priority 4, so for patients who need an outpatient appointment, the time they wait can be reduced by transforming the model of care. And here's where we get to the hub of the nub of the matter. This is an attempt, and it could well be successful, in changing the entire model of care, in actually changing the system of care, away from an NHS universal access, tax-funded, non-profit organisation and treatments, to a profit-making one. And I'll show you how they're going to do that. Well, they're not actually hiding it, although they're trying. So they've said rightly, we need to increase service capacity. You'll note this will include a strengthened relationship with independent sector providers to accelerate recovery. And then we talk about more people offered the option of treatment by high quality independent sector providers, free at the point of care. So there we have it. That is the kind of key thing with patient choice. They go on to talk about how they're going to use the NHS app, so the patient can access their files, and the patients can stay on top of their healthcare journey. All great, all wonderful stuff, if it didn't have the ulterior motive and we weren't in the current situation we are in now. At this point in time, we'll get to that, what we actually should be doing. But so we're going to get to a situation where you go and see your GP. Let's say you've got blood in your stool and you're in a risk category for cancer. You go to your GP. GP says, look, I'm worried. I think we need to get a test done. You need to get a colonoscopy. Okay, that's a camera up the bottom to see if you've got cancer. So, okay, fine. I'm going to refer you. So the GP refers. Okay, now, whereas now the GP has quite a bit of say in who you get referred to. Actually, there's a really good surgeon here, or actually I know the waiting list is low here, or you prefer to go to this hospital. Okay, we'll refer you there. So the GP has more control. Less over time, but more. Now what's going to happen is that referral is going to go in. It's going to link up to the NHS app. And on your phone it's going to come, your GP has referred you for a colonoscopy. Here are the waits. Here are your options. You can go to the private hospital X, waiting time 3 days, or you can go to your NHS hospital, waiting time 2 weeks. 5 weeks, whatever it may be. They're going to use patient choice as a way of forcing people to go into the private sector, and with it take the money with them. Now, nobody would blame a patient for doing that. And actually, if you had the choice, absolutely take the shortest way, as long as they're decent, that they're good at doing their job. Do the shortest route possible, particularly if it's things like cancer. No fault, you need a knee operation, you're getting offered it somewhere, you're not having to pay for it, fine, you take it. I mean, that is an absolute, it's not up to you to fight, to be stubborn and say, well, I believe in the NHS, I'm going to wait 2 years for my knee operation. No, you take it. This is not a fight that we're going to win patient to patient. This is a fight that we're going to win with the public, and this is with public uproar and voting the suckers out. I mean, that's a really important part of it, and forcing whoever's coming in to change some of the stuff. So anyway, you get your app, you go for your endoscopy, they take a biopsy. Unfortunately, the biopsy comes back positive, and it says you need to discuss the biopsy results. Here are your options. 5 weeks for this wait. Same thing again. Okay, I'm going to choose the shortest one. Again, the money. It's no longer that the NHS is contracting a private hospital. It's actually that if the patient goes there, the money goes with them. So massive change, huge change. Brilliant for the private sector. I mean, they're laughing all the way to the bank with that. They can circumvent the waiting lists, and partly because all they're doing are those treatments and those investigations. They're not having to deal with a hospital full of complex patients that you can't get a hospital because they're too unwell, and you can't get a hospital because there's no social care, and this flood of new acute patients. You've got COVID on top of that. We're having to deal with all of that and still provide that service, and they're just sitting there providing the easy stuff, and it is easy stuff for sure. And yeah, if it gets complicated, they'll send them back our way. Unfortunately, the NHS will be in such a state by that point, that we won't be able to do very much. And you see how the greed and the willingness to try and extract money, our money that you could put into strengthening the NHS, much cheaper to do an endoscopy in the NHS than it is to do in the private sector. And it may be the same person that does it. Quality may be similar, or such like. But it's cheaper in the NHS, by far cheaper in the NHS. You employ the consultant, you've got their work timetable set out. But in the other one, you're getting paid per service. Every time you do an endoscopy, you get paid. And actually, probably eventually, quality will suffer as it has in countries like the States and such like, as they try and extract more profit out of it. Nonetheless, the point being that they're pulling resource away from the National Health Service, which you want really, really strong. You want the National Health Service to be the best. And yeah, if you want to use private healthcare to do top-up things, you want to provide it as an opportunity for people who with private cover to go and get their tests and their treatments and things, then fine, by all means, that's freedom of choice, fine. But that's not what this is. This is creating a huge waiting list, short staffing, social care shortage, a system that you cannot logically choose to wait in when there's another alternative over there. No fault to the patient at all. So this is the final part of, well, not the final part, there'll be more, but it's a big part of further privatising it. So let's have a look and see. Let's have a look and see what. Sorry about that. Hold on a wee second. Here it is there. So this is, we're now on to the Scotland's NHS recovery plan, and this is a lot different. a lot different. And actually, I would say it's not it's not anything to write home about in terms of. I wouldn't say it was doing anything particularly revolutionary or hugely socialist or anything like that. It's just basic stuff. I mean, really, really basic stuff. Clearly, this was produced when Hamza Yusuf was still health secretary, and clearly they've listened. Hamza's listened to his medical expertise there, his medical experts there, because this is a clinically based plan for recovery. And you'll notice in the contents, it goes straight, the very first thing it talks about, not mentioned hardly at all in the government's plan, in the UK government's plan, staffing and well-being. Their priority is I think they're putting 10 million into 8 million, sorry, into just the mental and emotional health of the staff. We acknowledge that the last few years have been really tough, and we acknowledge that we cannot affect change without the staff. So their major thing is we're going to recruit more, we're going to retain our staff, we're going to treat them better, and it comes through in their priorities. Now the actual total figure is 1 billion, which of course is about double what relative to population, what NHS England are doing. But you can see investment in, I don't know if you can read that, sorry. Investment in support for staff wellbeing is therefore an essential and vital component of this recovery plan. And actually, they're aiming to increase, not capacity, like it said in the UK government's plan. That's just capacity. It didn't say NHS capacity. This says we're going to increase NHS capacity by at least 10%. Now, the reality is it needs to be 30%. And again, when you look at the analysis, that's what it shows. But the point is they're going to boost the NHS. That's their priority. We intend on taking to recover all the integral parts of our health service. They're not cherry picking here. This is the whole service that's going to benefit. And then we need to boost the whole service. Significantly, we are recruiting more staff throughout the NHS so our ambitious recovery can be fully realised. And they talk about what staff they're going to recruit. That's their point one, staff. And unless your head's been buried in the sand for a while, the rate limiter, the bottleneck, the only way in which any meaningful recovery is going to happen is if you deal with the staff crisis. Unequivocally. There's no way of dodging that. There's no way of shortcutting that. The only way to deal with that is with staff, and NHS Scotland right on the money here. And then they go into the details of which I won't go into. They're prioritising primary care. There's a 25% increase in their funding. They're giving 10 million to mental health. So there's more, particularly child mental health. They're giving more money, I can't remember, 25 mil to urgent care. And yeah, they're building diagnostic hubs and they're trying to expand the bed capacity of the NHS. And they're rolling out hospital at home as well. So as a clinician, and obviously I have a background in health systems, as a physician, if you're telling me at this point in time, what do you need? And what we need are boots on the ground, and we need front door, and we need space and resource to treat patients in the hospital. At the moment, all we're doing is constantly managing a bed crisis. Bed capacity has been above 95% in the UK. That's 10% over safe levels for ages now. We need more capacity, and we need more staff for that capacity. So those are the things I would do. I would restore pay to certainly to doctors, nurses, and key frontline staff, but probably all NHS staff. I think you would need to do. Um, uh, I would increase the bed capacity by 30%, not bed capacity, the capacity by 30%, and absolutely fully support primary care. And actually, you're probably looking at a doubling of funding for primary care, which again, contextually wise, is about, it's a little bit less than what we're giving to the private sector just now. It would take to double primary care, and that's the way you recover. Not, forget the NHS. Oh, the NHS, we all love the NHS. Forget that. That's the way you make sure that your public have a reasonable access to healthcare. That when I phone an ambulance, the ambulance is going to come. When I pitch up an A&E, I'm not going to be sitting there for a day waiting to get admitted. When I've got diagnosed with cancer, I'm not waiting 2 months to start treatment. If you want that kind of health service, then that's what you need. You're going to need to just restore pay to the NHS workers. I think personally, out of the vast majority of staff out there and people doing jobs out there, yeah, they do deserve it. Yeah, they do deserve it. And maybe you want to front load that so the lowest earners in the NHS get pay restoration first. Whatever. But I think they deserve it. And whether they deserve it or not, they're all leaving. So unless you pay them, they're going to leave. And even if you do pay them, they may still leave. So you maybe need to treat them a bit better as well. And I think NHS Scotland certainly on paper are looking like they want to do that. Loads of problems in NHS Scotland, but at least the government have the priorities right. And then the next thing, increase capacity of the health service. And it's going to cost you money. And actually, it's probably going to cost you what you should have been putting in since 2010. Had Labour, and I'm not a Labour member or anything, but I'm just not a fan of this government, the Tory government, but had Labour continued their trend through from 2010, and they continued that funding trend to the NHS, then we would have had 30 billion a year extra in the NHS year on year. So, in total, it's about 300 billion, but we're short over that time. So, increasing the budget for frontline services, to give staff pay restoration, to increase the bed capacity, to get some retention and recruitment sorted, and by God, to put some money into the primary care service. That's the way to fix the NHS. And it's not, I'm not claiming to be a genius. Oh, I've just discovered this, magical formula on how to provide healthcare to the population. This is basic stuff. This is absolutely basic stuff. You can speak to anyone in the sector, well-intentioned person in the sector, and they'll say exactly the same thing to you. You probably add on social care. We definitely got a huge social care crisis. You probably add in boosting that as well. And you may add in things like to try and reduce transmissible diseases, such as filtration systems in buildings and schools and things. You could add that in as well. It would certainly save some of the resources and reduce demands. So there are other things you can add, but this isn't rocket science. This is very basic. And what we are exposing here, what the government are exposing in themselves, they're going to drive diagnostics up. There's going to be nowhere for those patients to go, but then they're going to give patient choice, and of course patients are going to choose the quickest route to get their treatment. And bye NHS. It will, if that goes through and it's not repealed by assuming they can repeal it by the next government, you can say bye to the NHS you've been used to. One of the most cost-effective health services in the world. What we paid for healthcare and what we got back is the envy of the world. I mean, it was incredibly efficient. It wasn't enough. We didn't pay enough. I think it could be managed a lot better, and I think we certainly could do better with it, and we should strive to do better with it. But for what we're paying, for what we're getting, it was truly remarkable. And those days are gone. I mean, all that's going to happen is you either pay the same and the care just gets crapper and rubbish and declines, and the quality of care goes down and the access to different treatments go down, and we can't afford this new treatment and we can't afford that new treatment, and you can't afford to go to a care home. You have to stay at home. We can't afford to keep you in any longer. You have to go. It's just all going to get very, 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 very tight and very rationed. If this goes through and money is following the patient, it's the crucial difference. The money following the patient, then we're in trouble. And I think a lot of us would see already recovering NHS England as very, very difficult to get it back to where it was. I actually can't see a way of quickly doing that. What you can pray for is that there's a leadership out there that gets it. The public want it. The public want it to be the money to go into the NHS, but they can get it. They can sell it. They can sell the idea of it to the public and deliver a huge restoration in the National Health Service, like Labour's done before. I mean, in '97, Labour did do that. So unless we do that, then I just can't see a way of it recovering. And certainly, if this goes through, we're just, we're going to be trying for years to get this back. So, yeah. So that's what I wanted to share with you. You're going to hear a lot about patient choice. You're going to hear how fantastic it is. And yeah, initially, for everyone waiting, for the millions waiting, a lot of them will really appreciate that. So long as they don't get complications from it, they will appreciate it. It will help them. The reality is, though, it's almost a bribe, isn't it? That will fix you now, but it means that people in the future are really going to struggle when they need healthcare, when you need mental health services, when you need A&E, when you need, your granny needs looking after, or you've got a very complex cancer surgery, or a really bad brain bleed, or a really complex cardiac issue, sepsis, all the things that actually do kill people and disable people. When you've got that stuff in the time to come, the NHS isn't going to be big enough to help you. It's not going to help you like it did in 2008. So, we will miss it when it's gone. But patient choice, be wary, ask some questions, hold them